Hi everyone, and welcome to another edition of Eyecare Today. I'm your host, Dr. Thomas Kislan, and just to remind everyone, we're coming to you from our Hazleton location, which is Hazleton Eye Specialist on the Beltway in Hazleton. Our phone number is 453-2020. If there's any questions ever, please feel free to give our office a call. You can check us out online. Our website is www.drkislan.com. And for the patients watching us in our Stroudsburg location, the Stroudsburg area, our office there is Stroudsburg Eye Specialist, and the phone number is 421-3342. So again, feel free to give us a call if there's any questions. Folks, I'm honored today and very happy to have with us Dr. Sachin Patel. He's our retina specialist here at our Hazleton location. He's been with us over a year now and providing great retina care to patients in the Hazleton area. So, Dr. Patel, I appreciate you coming in and talking to us about what the latest and greatest in retina care. Thanks for coming in and taking the time.
Thanks for having me, Dr. Kislan.
Let's just start. Tell the folks out there a little bit about yourself. I mean, you're local guy, born and bred in Scranton, right?
Correct. Well, I was born in New Jersey, but I moved to Scranton at the age of 1, so I consider myself born there, basically.
Okay.
But I actually had a different experience than most people. After finishing my training at Nassau County Medical Center in Stony Brook and Long Island, I went into practice in Oslo, Norway, worked there for the past 3 years, and then just recently came back to the area a year and a half ago and started private practice in Clark Summit. And I work out of your office here in Hazleton.
Right. And tell us a little bit about the experience in Norway. What was that like?
Well, it's a little bit more like socialized medicine. It was a great experience. The major differences are you have super specialists there that deal with just the surgical aspects of the disease and other people who deal with the medical aspects of the disease. So
you did just surgery, basically?
In the world of retina, all I did is operate and did surgical retina out there.
So, I mean, that, I guess, not dealing with the patient side, but more the surgical end, you got just great surgical experience.
Better than I could have ever dreamed of.
Right. So that benefits our patients here in the States now, because now you're in our area, and if a patient needs surgical retina care, I mean, you probably have more experience than most surgeons in this area being able to provide that care.
Well, I do have a tremendous amount of experience.
Great. So let's talk about the things that affect our patients that we see on an everyday basis. Probably one of the biggest conditions is macular degeneration.
Okay.
Macular degeneration is a devastating disease, and folks, what we're going to do is kind of dive into this a little bit. Explain a little bit to the people out there watching, what exactly is macular degeneration?
Macular degeneration is a disease of elderly people who are generally light-skinned, but it does affect everybody. People who have darker skin, it affects them a few years later, maybe about 10 years or so. And what happens is certain layers of the retina start to degenerate and degrade over time. And it's very common. If you took people over the age of 75, approximately 25 to 33% of them will have some kind of form of macular degeneration, albeit most of them will be early.
Okay.
If you took people over the age of 55 to 65, it's not going to be as common, but 65 over, you're looking at a significant number of people who have the early changes of macular degeneration.
So in theory, patients get to around the age of 50 is when we could start, especially if they're fair complected, that's when we could start seeing some of these early changes.
Well, Dr. Kislan, I recommend every patient over the age of 40 get a screening eye exam, because it's not just macular degeneration. There's a bunch of other eye diseases, as you know, which start to occur around that age. People start at the early stages of glaucoma and other things. So I think everybody at the age of 40 should get their first screening eye exam if they haven't been getting a yearly eye exam. That's
a great point, because a lot of people think, well, maybe my glasses don't need to be changed, or I see well, why do I need to get my eyes examined? And that's a great point, because there are other conditions out there that can affect the vision besides just needing new glasses.
Definitely. But especially people over the age of 60, they're the ones that really need a yearly eye exam.
So explain a little bit of the difference. There's different types of macular degeneration. So, we've heard thrown around the terms dry, wet. Explain, let's talk about dry macular degeneration first. What exactly goes on with dry macular degeneration? So
the difference between the dry form and the wet form is the formation of new blood vessels. Both forms can cause a decrease in vision. The problem with the dry form is that it happens so slowly and in a stepwise fashion that people don't realize that their vision is being lost. Whereas the wet form suddenly comes and it takes the vision away by a leak or a bleed in the eye. The dry form is very common. 90% of people who have macular degeneration have the dry form. The main treatments that we have for the dry form, well, we'll get into the treatments as we go on.
Yeah. So when you look at the retina, when I look at the retina and we're examining a patient, just explain to the folks, and we're going to try to throw some pictures up on the screen while we're talking, but what's going on with the retina in the dry form?
In the dry form, certain pigments are being deposited in the layers of the retina, which form drusen and different types of deposits that accumulate over time. Most of the time, these deposits are stable and they don't progress very fast, but sometimes they progress and cause a decrease in vision and vision loss. So it's an aging change which causes degeneration of the layers of the retina.
So just like the name macular degeneration says, the retina starts to degenerate away, and that's exactly why patients can't see. And it's usually the central vision that's affected in these patients rather than peripheral vision. And to your point before about getting an eye exam, probably the two conditions in life that a patient would never want to have together is macular degeneration and glaucoma.
Because the one's taking the central vision, the other's taking the peripheral.
Right.
The two together take both.
Right. So that's a great reason why patients need to get their eyes checked. Now we talked a little bit about dry. Now let's go into a little more depth. The wet form. What exactly is going on? You mentioned some new blood vessel growth.
So in the where we left off at the dry form, we have some degeneration in the retina, and the layers of the retina become calcific and they become a little hardened. It's kind of like the pavement that you see outside. Gets cracks in it, and then you see the weeds grow into it. What's happening is when these layers are getting calcified and hardened, they sometimes get breaks in it, and new blood vessels form through into the layers of the retina, and they start to leak and decrease the vision. They start to bleed into the different layers of the retina, and that's what the wet form is.
So the term wet comes from those blood vessels that grow. Now, if those blood vessels grow, that's not necessarily where the problem is. It's when they leak, right? And when they start to bleed, that really...
If we can catch them at the stage where they're growing, we can prevent a lot.
Right.
But most of the time, it's when they bleed is when the patients first notice it, and that brings them into the eye doctor. So
right back to the importance of getting checked, because if you catch the blood vessels before they break, there's some treatments which we're going to talk about that can really help those patients.
Correct.
How do we, besides just examining the patient, what technology do you use to diagnose this?
We have different screening tools and different tests that we do to help decide what's going on. One of the latest things we've been using now is called an OCT, and it's a scanning laser which checks the layers of the retina, which, to begin with, the retina's got the thickness of 250 micrometers. It's as thick as a tomato skin, and that thing has 10 layers in it, and we're able to tell what each layer looks like now with this scanning laser.
That's amazing.
And we do that right here.
Yeah, technology really has allowed us to diagnose and treat these things early on before these patients really can have vision loss. Folks, what I want to do is we need to take a quick commercial break here. We're talking about macular degeneration. My guest is Dr. Sachin Patel, a retina specialist right here in Hazleton. We're going to talk lots more about retinal disease and retinal treatments when we come back. You're watching Eyecare Today, and we'll be right back. Hi folks, welcome back. Again, you're watching Eyecare Today. I'm your host, Dr. Thomas Kislan, and we're coming to you from our Hazleton location, again, Hazleton Eye Specialist. Again, our guest today is Dr. Sachin Patel. He's a retina specialist here in our Hazleton office, and we're talking about diseases and treatment of the retina. So again, Dr. Patel, thanks for coming in and spending some time with us today. Before the break, we were actually talking about the diagnosis of macular degeneration, and you had mentioned an instrument called an OCT, which is a scanning laser that actually helps detect macular degeneration. And you had mentioned, which I found interesting, the analogy of how thick the retina is. Tell the folks again at home that analogy of what you're working with on a daily basis and examining. How big is the retina?
It's as thick as the skin of a tomato. It's very, very thin.
That's amazing. So that's what allows us to see is an organ that small. So folks, I just think that's amazing. The technology we have now allows Dr. Patel to be able to diagnose and treat something that small. So that's fantastic. Let's go into the treatment now. So, patients,
Well,
let's
Tom,
say...
one other thing I wanted to talk about was the fluorescein angiogram. You asked about the diagnostic tools.
Yes.
Besides the OCT, we also take pictures of the eye, which let us monitor the condition as it progresses over time. We'll take color pictures, which will show us these aging changes, and we'll do it at baseline, and we'll do it again a year later or 6 months later, and we could see how the disease is progressing. Another thing we can do is we inject a dye called fluorescein in the hand, which will show us the areas of leakage, the problematic areas causing the decrease in vision.
That's a great point. I'm glad you brought that up because, what happens a lot in this office, if I see a patient that come into a routine exam and, we check their retina and I think there's something that doesn't look right and I suspect they have macular degeneration, immediately they're going to get an appointment with Dr. Patel, and what the patients can expect, we'll usually do that OCT that you talked about before they see you. So we'll have that kind of lets me know, is this an emergent visit or is it something that maybe could wait, 2 weeks or so. But then when they do see you, you're going to review the OCT, you're going to dilate the patient, look at the retina, and then they can expect most likely to have that fluorescein done, like you said, where a little injection's done, the dye goes up into the arm, into the head, into the eyes, you take all the pictures, and then that, correct me if I'm wrong, that allows you to target the area specifically with whatever treatment you deem necessary, whether it be, which we'll get into here, injections, laser, things like that.
Correct, Tom.
Okay, great. So, we talked about the dry and the wet form. Dry form, unfortunately, there's not much treatment for, except, there's been a lot of research now with supplements, certain nutritional supplements. So, being on the front lines of this every day, just give me your take on, your thoughts about nutrition and supplementation with macular degeneration.
Well, the two things I advise people with dry macular degeneration is if they have any comorbid problems, such as high blood pressure or diabetes, to have these things controlled. Most of the times when the dry form converts to the wet I'll notice if I check a blood pressure, it's been elevated, and that's what caused those new blood vessels that are forming to bleed. So that's the first thing that I tell them. The second thing is we have these multivitamins. It's called the AREDS formulation, which I asked them to take. These things have been shown to decrease the progression to advanced macular degeneration, to decrease it by 25%.
So, not only good health, making sure blood pressure is good, cholesterol, diabetes, nutrition. How about smoking?
Smoking is an absolute no-no for this. It also is shown to harden the arteries and to make the progression of the disease much more advanced. Smokers generally get a more severe bleed, and it's a bigger problem to control. Now,
I think I've read this, and correct me if I'm wrong, if a patient has dry macular degeneration and they smoke, their chance of progressing to wet is much higher. And also if they have wet in one eye and dry in the other, and again they smoke, their chance of converting from wet to the other eye is actually very high.
Correct.
Is that correct?
Yep.
So like you said, smoking's a big no-no. That's another reason we can throw at patients not to smoke.
Exactly.
Okay. So, we have wet macular degeneration now. We talked about, some nutrition, some supplementations for the dry form. The wet form now, what is out there as far as wet macular degeneration for treatment?
Wet macular degeneration, historically, we didn't have many treatments available. If we look back 12 years ago, we had just focal laser.
Okay.
This was a treatment that we took a condition that was progressing and we brought it to its end point, and patients didn't see better, they saw worse. But we controlled it in a way where we didn't decrease peripheral vision or increase their central scotoma.
Okay.
Now we have amazing treatments available that have started in 2005, which are injections in the eye that help control these blood vessels. So now we're actually able to stop the progression of the disease and improve vision.
Okay.
40% of the patients were probably improving. 95% were stabilizing or improving.
Wow, that's amazing.
Compared to before, everybody got worse.
Right. Now, and as time has changed and technology has gone on, these injections have gotten better because we have 3 that are
There's
approved now.
3 approved, 4 total that we are using.
Okay.
The first injection, which people started using in 2005, was Macugen.
Okay.
That was a form that only targeted one of the isotopes
Okay.
of the growth factors which cause this disease to progress. In 2006 or 7, we came out with another one, Lucentis, which targeted all the isoforms of the growth factors. And this worked great up until now. The only problem was that patients needed injections monthly, or if they were lucky, they got 5 or 6 weeks out of injections. Some people got more.
Okay.
But it was a huge burden for people to come back repeatedly to have injections over and over. Luckily, recently, I believe it's about 1 year now, we have a new drug called Eylea, which targets the same isoforms, but it also targets another one, placental growth factor.
Okay.
And now we're able to extend injections out to about every 2 months in most people.
Wow. Now, when a patient comes in for an injection, now I'm a big baby, so you're not getting anywhere near me with a needle, but
Don't worry, you're not getting near me either.
but I've had patients tell me that the injection is less bothersome than if they get lidocaine from their dentist or Novocaine from their dentist.
There's different ways of doing it. We can take care of it so that the patient does not feel the injection. We can give them a small lidocaine injection underneath the skin of the eye so they don't feel the injection at all.
Okay.
Actually, the biggest problem I hear patients complain of is the eye drops that we put in burn.
Right.
So that is the worst of the injection.
And folks, I can tell you a lot of my patients have had the injection with Dr. Patel, and they say he's got great hands and don't feel it all. So, you know, if it is something, if it is a treatment that you may need, it is really not that bad. And like you said, 95% almost success rate.
Stabilizer improved.
Right, is fantastic for a condition that, like you said, years ago, we really didn't have much to do for. So again, technology and you know, physicians like Dr. Patel have just done great things for this condition. Folks, what I want to do is we're going to take another quick break, and when we come back, we're going to talk more about retinal care, disease, treatments of the retina. Again, I'm your host, Dr. Thomas Kislan. We're here with Dr. Sachin Patel, and we'll be right back. Hello everyone, welcome back. Again, I'm your host, Dr. Thomas Kislan, and you're watching Eyecare Today. Again, I'm pleased to be here with Dr. Sachin Patel. He's director of the Patel Retina Clinic, whose main location is in Clark Summit, but we're very fortunate to have Dr. Patel here in our office as our staff retina specialist here. So we're talking about macular degeneration, diseases of the retina. Over the break, Dr. Patel, we were talking a little bit about the vitamins and the ARED study that we had mentioned, and the one thing that I just want to reiterate to patients is not only the vitamins are extremely important, but there's actually research now about omega-3s. And everyone out there, if you've seen my show before, you've seen me talk about the importance of omega-3s. We use the physician-recommended nutraceutical brand, which has a formulation that was actually helped develop by Will's Eye down in Philadelphia. It's an omega-3 with lutein, zeaxanthin, and vitamin D3. So that, along with the AREDS formula of vitamin, has really helped our patients. Anything else that maybe we missed on that we want to touch on?
There's also the genetic testing that we could talk about.
Yeah, that's a great point. The genetic testing, and about 2 shows ago we did a little bit on the genetic testing. Again, genetic testing has become extremely prevalent in medicine now, and one of the areas in eye care where it's being used is we can now take a cheek swab. It's a simple swab of the inside of the cheek. It gets sent to a lab, and they've actually now found a gene specific for macular degeneration. And what this does, everyone, is it just predicts a patient's risk for progression of their disease. So it takes into account age, race, sex, do they smoke, and then the genetic factors, and gives us a score as far as whether they're going to progress or not. And why this is important is if they're a high risk, it just means maybe we need to see them on a more regular basis, make sure that they're on their supplements, make sure they're not smoking, make sure they're getting proper cardiovascular care like you had mentioned. So if there's any questions about the genetic testing, please feel free to contact our office. Anyone who's been diagnosed with macular degeneration, I think it's just a great tool, another piece of the puzzle to help us provide great care to our patients. So again, folks, if there's any questions on macular degeneration, please feel free to contact the office, and either one of us will be glad to discuss that with you. Probably the next biggest condition that affects patients is diabetes and diabetic retinopathy. You know, besides macular degeneration, I mean, diabetes is a killer out there. As far as general health, we see patients all the time in practice. They're insulin dependent, non-insulin dependent, and that can affect the eyes. So explain to our viewers out there what happens with diabetes that it affects the eyes. Why do family doctors harp on them to get your eyes checked every year?
Well, Dr. Kislan, the main thing with diabetes is the elevated blood sugar is happening in every organ of the body. So it's a systemic disease. It's not just affecting the eye. But in the eye, we notice that what happens is the normal blood vessels of the eye shut down and new blood vessels start to form. And these new blood vessels bleed and leak, and they decrease the vision. They're saying that 1 out of 3 to 1 out of 4 people born today will be a diabetic.
Wow.
It's a worldwide epidemic.
It's amazing. And why do you think is that? Is it our diets? Is it that we're not exercising enough? Well,
I think it's a combination of our diets, eating more processed foods,
okay.
Inactivity, and we're living longer.
Okay, yeah. So is there a correlation between good blood sugar control and what you see in the eye?
Absolutely. Even if you're diagnosed with diabetes, if you take good control of your blood sugar, you won't go on to get the retinopathy that you would if you had uncontrolled blood sugars. You have a good chance of not developing retinopathy if you keep your sugars controlled.
So just like before in our first segment, you had said that every patient over 40 should get their eyes checked. How important is it for a patient with diabetes to get an eye exam?
Every patient with diabetes should be sent to an eye care specialist.
At least once a year, right?
At the minimum,
At the
yes.
minimum. So again, the diagnosis of retinopathy, is it pretty much the same as with macular degeneration? I mean, you're dilating the eyes and looking and...
Our diagnostic tools are, for the most part, they are the same. We do the scanning laser also to pick up how thick the retina is. Remember the tomato skin, that thing swells up in diabetics also. We also use the fluorescein angiogram and pictures to monitor progression of bleeding and diabetic retinopathy over different stages of time.
Okay. And so when a patient has diabetic retinopathy, there's probably stages, some is probably mild, some is more severe. What, when you look in the eye, what do you see that would cause you to say, well, that's a severe case that maybe we need to treat?
The severe cases have more extensive bleeding and new blood vessel formation. The things which make it very high risk are bleeding into the vitreous cavity or detaching the retina.
Okay.
So those are very advanced. Now we're getting into a condition which we used to be treated with lasers and injections into something that now needs surgical treatments.
So, just to kind of let the folks, again, we're going to try to throw a picture up here while we're talking, but bleeding in the retina is bad. I mean, that's not something that we usually have. Whenever there's blood in the retina, leaking blood, I should say, fluid in the retina or swelling. I mean, just like a patient twists their ankle swells up. That's maybe not the greatest analogy, but you can get that type of fluid in the retina that causes blurry vision. So any blood or fluid in the retina is bad.
Correct.
And that's what you need to control, again, either with some of the treatments. Now let's talk about some of these treatments. So there's laser, correct?
Yes, the gold standard from early trials was laser.
Okay.
But currently we're seeing a shift now. People are now using the same drugs that we inject for macular degeneration. We're using those to treat the new blood vessel formation in diabetics as well.
So the new blood vessel formation and they get swelling in the retina, you can use those injections. How about steroid injections? Is that still used?
It is still used, but less frequently. The side effects of steroids make it a secondary choice.
Okay.
And the side effects are their cataracts usually progress and they have problems with glaucoma.
And a few years ago, didn't a steroid implant come out? Wasn't that FDA approved for?
It is FDA approved, but it's not approved for diabetics.
Okay. Okay. There's other conditions that you can get swelling in the retina that this is approved for.
The implants, you're correct.
Okay.
They are still in studies. The implant may be approved in a year or so, if we're lucky.
But right now, you've got some injections you can use of some medicines that's doing really well.
Yep.
And let's talk a little bit about, you mentioned briefly the worst case scenario. So let's say these conditions progress, and you mentioned a bleed into the vitreous cavity. That's called a vitreous hemorrhage. That is a very vision-affecting condition for patients. Their vision really goes bad fast.
It's scary.
But in the early stages, there's not much to do for it, right? You kind of have to let it...
Yeah, give it a chance to settle out and see what's causing it. And then the treatment for that would be to find the leak and try to do some laser treatments to help prevent a rebleed from happening.
And some patients actually will see floaters initially before the bleed actually happens, correct?
Those floaters are the bleed that's happening.
The bleed that's actually
And sometimes they just get a small bleed and they just see a few floaters.
So as soon as they see those floaters, what should they do?
You should get an eye specialist to take a look.
They need to get on the phone, call our office, call you, and get seen. Because the analogy I use, folks, if you ever see those little snow globes at Christmas that you shake up and you have all the white floating around, that's sometimes what patients will see. They'll see all these spots floating around. And in a diabetic, the new onset of spots is usually not a great sign. So they need to get in and see us real quick. And then you mentioned probably worst case scenario is a retinal detachment. How's that treated?
Once the retina is detaching, now we're at a surgical treatment. The prognosis goes down, but it is still a favorable prognosis to have surgery.
As long as it's caught quickly.
The earlier you catch it, the better off you are.
Okay.
Now we're talking about vitrectomy surgery where you go to the operating room. It's the same day surgery. We go in, we take out the jelly, we peel any kind of traction membranes that we see and try to put the retina back into place with different tools and then laser around the area of traction. And that's the gist of the surgery.
So I think, you know, we covered a lot in this last show, and I just want to remind people out there, we're actually going to do a two-part show with Dr. Patel. He's going to be back. Our next show is going to be part 2 of retina diagnosis and treatment of retinal conditions. But just to sum up, you know, we talked about macular degeneration, diabetes. Patients need to get their eyes checked on a routine basis so we can catch these conditions early, and if they need treatment, they get to a specialist like Dr. Patel. So again, Dr. Patel, thank you very much for coming in and sharing your insights with
Dr. Kislan, thank you for having
patients.
me.
What we're going to do, folks, we got to stop here. We're out of time. So again, look for our second show, part 2 with Dr. Patel. Again, thanks for watching. You're watching Eyecare Today. I'm your host, Dr. Thomas Kislan, and we'll see you next time.